weeks where we stopped. So this is the patient we discussed, this 59-year-old man who came with a creatinine of 310, had a GFR of 19.2. And after the discussion, we concluded that this patient is having CKD, and we discussed about the management and how to minimize the progression of CKD for this patient. And then this is where we stopped last time. So you've done all the management steps for this patient. You've tried to control all the complications, the progression factors. However, with time, this patient's creatinine has gradually increased, and 1 year later, his creatinine now has increased to 410 micromoles per liter, and the GFR has dropped to 14 milliliters per minute, 1.73 square meters. Now, what would be the next step in the management? So this is a time where we start now thinking about renal replacement therapy. Now, all these patients, your usual CKD management that we discussed last time has to continue for this patient. But on top of that, when their GFR reaches less than, say, around 15 or less than that, when they're in stage 5, that is when we start thinking about renal replacement therapy and preparation for these patients. So just to refresh our memory, we spoke about the CKD stages according to GFR, and we said that less than 15 GFR is stage 5, or the end stage of kidney diseases. So what are the absolute indications to start renal replacement therapy? So that is refractory hyperkalemia, refractory metabolic acidosis, fluid overload, uremic symptoms like uremic pericarditis, encephalopathy, and if they are severely, oliguric or anuric with volume overload status, those are the times when we think about starting renal replacement therapy for patients with advanced CKD. Having said that, these are very variable depending on the patient, depending on the symptoms. It might vary, but these are generally some of the common indications. So what are the treatment options for renal replacement therapy for our patient? So these are the main modalities of renal replacement therapy we talk about. When a patient develops end-stage renal disease, a patient can go on to hemodialyze later if kidney function significantly declines. A patient can either decide on doing peritoneal dialysis. A patient can directly go for transplant without doing hemodialysis or peritoneal dialysis. Most of the patients, however, once they reach end stage, and if they have one of those indications, you start hemodialysis and then go for a kidney transplant. Similarly, with peritoneal dialysis, they would later go for a kidney transplant. And but not all patients would be suitable for all these modalities. There will be a group of patients where they are not stable for PD, hemodialysis, kidney transplant, or they wish that their wish is not to go for any of this therapy. They would go for what is called medical management or comfort care for these, or conservative management in these sort of patients. If you look at this diagram, the other important thing to identify is that you should not think of this renal replacement therapy as a straight line where you have a patient with end stage, has hemodialysis, kidney transplant, and that's over. You should not look at it like that. This is a continuous cycle. For example, a patient might develop end stage kidney disease. You might start hemodialysis for the patient. Then the patient will go on to transplant. However, on average, a kidney transplant will last up to around 5 to 10 years in the majority of patients. So after 10 years, your kidney transplant fails. And that is not the end of the story for that patient. You can again think of going back to hemodialysis or peritoneal dialysis. And then again, once a transplant recipient is there, again the patient can go for a second kidney transplant. Similarly, again, if that fails, you can again go back into dialysis. And once you have another transplant candidate, you can do a kidney transplant. So likewise, you can do 2-3 kidney transplants in a patient depending on their requirements. So, and that is what is shown here. So you go there and it goes in cycles. So the main two dialysis options remains hemodialysis and peritoneal dialysis. And when we talk about hemodialysis, we talk about in-center hemodialysis, that is where the patient has to come to hospital for dialysis, or home hemodialysis, where the patient can get a dialysis machine and do dialysis at home. In Sri Lanka, we don't have home hemodialysis. We only do in-center hemodialysis, where the patient has to come from home for hemodialysis. Peritoneal dialysis, you have two ways of doing it. CAPD stands for chronic ambulatory peritoneal dialysis, and APD stands for automated peritoneal dialysis. We will discuss this in a bit later. CAPD means you do it manually, right? So I will show you a few pictures later where the patient can do this manually. And APD is you have a small machine where automatically the machine will do peritoneal dialysis for these patients. So in Sri Lanka, CAPD is the commonly available one. Automated peritoneal dialysis is just being started, and the only center that does it in a smaller scale at the moment is Kandy Hospital in the whole of Sri Lanka. So we also now have a little bit of automated peritoneal dialysis. Now, before going on for renal replacement therapy, the most important thing is these patients and the family need a lot of education regarding CKD and future renal replacement therapy. You need to talk to the patients needs to be referred to a renal nephrology service. You need to start the CKD progression strategies. They need to start getting education, and they need to be introduced to these modalities of renal replacement therapy when they reach a GFR around 15 or less than that. They need to be given vaccination like hepatitis B, pneumococcal, hepatitis B mainly because these patients are going to deal with a lot of blood in the future where dialysis, transplant, so you need to vaccinate them against that. And pneumococcal also is to reduce the respiratory tract infections. Your family needs to be educated very, very well because this is not a problem a patient can manage alone. They need a lot of psychological and social support. So the family needs to be fully aware of this problem. And then depending on the modality of renal replacement therapy, you need to start preparing these patients for access. For example, if it's a patient who's going on for hemodialysis, you need to start preparing with the AV fistula for these patients. If it's a peritoneal dialysis patient, you need to get a PD catheter for these patients. So there's a lot of preparation going on. And also, if this patient is going to do peritoneal dialysis, the house and the home environment needs to be made and prepared before these patients go home for CAPD. So a lot of education, a lot of discussions, a lot of planning goes before these patients start on renal replacement therapy. Unfortunately, this is exactly the most important thing. A lot of times is forgotten, and when these patients, most of these patients are referred late to renal nephrology services, and hardly any of them have got a lot of education regarding their disease. So that is something that's too often forgotten and something that's very important in the management of these patients. Right, so we'll talk a little bit about hemodialysis first. So this is a patient on hemodialysis. So you can see the patient here. Now this is the AV fistula that's been created, and you can see the blood lines here. So the blood is going to come out of that line, and it's going to go into the hemodialysis machine. And this is the filter, and the blood is going to get purified within this filter and put back into the patient. So you don't need to know about what happens in dialysis and what sort of things happen here. Just if you just have a basic idea about what the hemodialysis is, that's more than adequate. So this is what happens in hemodialysis. So you have an AV fistula that you need to create. You have an artery and a vein. So from the arterial side, you put a needle, and then through that the blood is taken out. It goes into the dialysis machine. And then there is a filter which will purify the blood, that is taking out all the toxins out of the body. And the clean blood is again going to be put back to another needle back into the patient's circulation. So that is basically what happens at a hemodialysis session. And in general, one of these sessions take about 4 hours to do. And patients have to go into hospital for around 2 or 3 sessions per week for the rest of their life once they start hemodialysis. Now this is the filter. So in the picture I showed you, this is the filter that purifies the blood, and this is what it's looking like at a closer view. This is a filter, and inside this you have a lot of fibers, very tiny fibers, which are very difficult to even see with the naked eye. And if you enlarge it further, inside the fiber you have a semi-permeable membrane. So what happens is, from one side through the fiber you send blood in the patient, and outside the fiber you send a dialysis fluid, and through diffusion all the toxins are taken out into this dialysis fluid, and the purified blood is the one that is going to go out of the dialyzer, and that is how it purifies blood within the dialysis filter. And if you look at the AV fistula in a patient, so I'm sure by now you have seen AV fistulas being created in your surgical appointments. If you haven't, don't worry, when you come to your prep appointment, when you do your surgical appointment, these things are done very frequently. So what happens is, you have a main artery in your hand and you have a vein. So they connect the artery to the vein, and this arterial blood directly goes into the vein. And with time what happens is, this vein is going to enlarge, because this pressure in the artery is directly going to get transmitted to the vein, and this is that part of the vein that has now gotten enlarged and big. So once that happens, you can easily put 1 or 2 needles into this during the dialysis session to take blood out and to send the good blood in. But the important thing to know is, after you make this AV fistula, it takes about 6 to 8 weeks for this fistula to nicely mature and be big like this in order to start dialysis. So that is why these fistulas need to be prepared early, before the patient actually needs dialysis, because even after creating, it takes about 2 months for it to properly mature for use. So that is why it needs a lot of planning ahead of the date of dialysis. So this is this is again another picture where you have put 2 needles, 1 needle there, 1 needle there into the fistula, and blood will come out of this red side and blood will be put back into the patient through this blue side. So apart from AV fistulas, there are different other accesses that we can use to do dialysis. Now the best one will be an AV fistula because it's more physiological and the infection risk is less. However, there are some patients who straight away come into hospital having a lot of symptoms, and where we can't wait for 2 months for an AV fistula to create. So what we have to do at that time, and if we need urgent dialysis, we use this temporary access to take blood out of the circulation. So here you see what we call a permanent catheter, a perm cath, where it is put into the internal jugular vein and then tunneled under the skin and brought out like that, so that this patient can easily wear their normal clothing and it's not going to be seen outside. And these sort of catheters can be kept for around 3 to 6 months without any problem in this patient, because the infections won't go in because it's tunneled under the skin. But if it's even more urgent, then we go for these temporary accesses called Vascats, where this line is again put there, but without being tunneled under the skin, it just comes out of the neck and sticks out like this. So this sort of vascular accesses, you don't keep it for more than a month, because the infection risk is high, because infections can very easily go in there. So these are temporary vascular accesses until you can get a AV fistula created for these patients. So when should this access be placed? Now this is the patient's graph, and if you look at this axis, on this axis you have the time. So starting from year 2000, 2001 to 2008, and on this axis we have GFR in a person, and this patient with CKD starts coming to the clinic when the GFR was around 37. And you can see over time his GFR has gradually declined, and by this time, by 2007, now it's come to a stage closer to GFR of 15. Now this is the time. Now if you had all these values in a graph, Now you can see that with time, if you wait for another few months, this graph is going to come down and the patient will need dialysis somewhere there. So at this point, that is where you start thinking of creating an AV fistula, so that by the time this kidney function drops somewhere there, then you already have a fistula created and you can start thinking of initiation of dialysis. So that is how you decide on when to put a AV fistula in a patient. As house officers, what is very important for you to know is that whenever these patients are planning for AV fistula creation, their non-dominant hand is the one that we use for fistula creation, and that needs to be preserved. Preserved in the sense the veins and the blood vessels need to be preserved without damaging. Therefore, whenever a patient with CKD comes to the ward, and if they are having plans of dialysis in the future, their non-dominant hand needs to be preserved at all times. Blood pressure measurements, IV drugs, taking blood cultures, none of that should be happening in the non-dominant hand. You should actually be doing that all in the dominant hand of these patients. Okay, so that's all you need to know about hemodialysis and just to get an idea about hemodialysis. Any questions up to that point regarding hemodialysis?
Excuse me, sir.
Yes.
So when an AV fistula is created, won't there be ischemia distal to the area where you channel blood from the artery to the vein?
Right. So that is one of the complications that you need to look for in these patients. But before a surgeon creates a AV fistula, they will always do a duplex scan of the hand to make sure that there are adequate collateral blood supply to the distal hand, so that even if one vascular is diverting blood, it will make sure the other blood vessels are going to take blood flow to the hand. But very, very rarely your distal hand can become ischemic, in which case again the surgeons will have to go in and ligate, remove that. But most of the time it doesn't happen because the surgeons always will look for other collateral blood supplies. Any other questions?
So why we have to preserve the non-dominant hand?
Yeah,
what cause if it's...
Yeah, so I'm sure by now you would know with your clinical experience that when you use veins in the hand for blood drawing and when giving IV antibiotics, these patients end up with thrombophlebitis, thrombosed blood vessels, things like that. So if that is the case, then if you want to create AV fistulas, they won't have good veins in the hand because it's already destroyed by previous cannulation or drug administration. Therefore, in order to preserve those veins, you should not be using that hand in advanced CKD patients waiting for dialysis. Any other questions?
Excuse me, sir.
Yes, one can start. Yes.
Sir, when you create a AV fistula, can it lead to complications such as high output cardiac failure?
Yes, so that is one complication, again a rare complication that can happen, because what the question, high cardiac output happens like this. Sometimes in patients this fistula becomes very big, and out of the cardiac output a lot of blood is diverted to the fistulas if the fistula becomes very big, and then the heart goes into heart failure because it has to keep pumping very fast and a lot of cardiac output. So that's also a very rare complication which you need to monitor for. If that happens, it's very easy. You just can ligate across the AV fistula if that is happening. Yes, that is one possible complication. Yes, there's one more question.
Sir, I wanted to know if there would be a pressure drop when we create an AV fistula, because from high pressure to low pressure, we just make a connection.
Yeah. So hemodialysis, we will discuss this later. Hemodialysis is not for all patients. You have to select the patients who are suitable for hemodialysis. If a patient is having significant heart failure, hypotension, those sort of patients are not going to be considered for hemodialysis because of the blood pressure fluctuations. So anyway, if you are creating a fistula, it's going to be a person whose blood pressures are stable, his heart is working fine without any problems. So in those sort of patients, AV fistula creation doesn't really cause any blood pressure changes. And also because they are using distal vasculature, the wrist and the elbow veins and arteries, that's not going to create a major blood pressure drop when creating of AV fistulas. Right, so I'll give you time to ask more questions at the end. So we'll go to the next segment, peritoneal dialysis. Now, this is not the peritoneal dialysis. If you have seen acute peritoneal dialysis in the hospital settings where patient comes with an acute kidney injury and you do peritoneal dialysis where there is a small needle that's a small tube, sort of a straight catheter that's been put into the abdomen and the patient's bed bound and there's a fluid running. That's not the peritoneal dialysis I'm talking here. That peritoneal dialysis is what is called acute peritoneal dialysis. But here, this is what is called CAPD or ambulatory peritoneal dialysis, which is used for end-stage kidney disease patients. So the basic principle here is you have the abdomen and this is your peritoneal cavity. You put this catheter into the peritoneal cavity and that can be kept for years and years without any problem. What the patient has to do is, there is a dialysis fluid. They need to connect this tube into the dialysis fluid and this dialysis fluid is put into their peritoneal cavity. You let it be there for 3 or 4 hours. And during that time, what happens is, according to a diffusion gradient, all the toxins in the body are going to come out into this peritoneal fluid. And after 3 or 4 hours, you remove that fluid out of the peritoneal cavity. And that way, you are indirectly clearing out all the toxic materials in the body. So that is the principle of how a peritoneal dialysis works. Now, just to show you some pictures, so this is how it will look like when you put in a CAPD catheter. The rest of the catheter is inside the peritoneal cavity, and only a small part, this tube is just going to keep hanging out so that you can always wear whatever you want on top of that. And this is a person who's doing peritoneal dialysis at home, and you can see this is the peritoneal fluid. So what he's doing is he's connecting this peritoneal fluid to this tube and putting this fluid into his peritoneal cavity. And he then, after putting that, he can disconnect it here. And then 3 or 4 hours, he will just go around, do his own things, go for work if he has to. And after 4 hours, he has to come back to some place and remove that fluid from the peritoneal cavity. So that's how a CAPD or peritoneal dialysis works. And this is the same principle as in the hemodialysis. So if you think of this as the peritoneal membrane, on one side you have the blood vessels of the peritoneal cavity, and the other side you have the peritoneal dialysis fluid. So all your toxins are going to go through this semi-permeable peritoneal dialysis membrane out into the peritoneal cavity, and you can remove it from there. And that is how it works. And this is a laparoscopic view inside the peritoneal cavity. So once you put the peritoneal cavity, so inside the peritoneal cavity, it will be like this. It will be a coiled catheter. It will just like this in the peritoneal cavity. And when you put fluid in, this whole cavity will get filled with peritoneal dialysis fluid, and you just have to remove it. And when you take, so that's the inside of the peritoneum, and outside you can take it out of the skin like this, and it will just have a small piece outside sticking like this. That's all. Now, that sort of thing, the picture I showed you is how you do it manually. So here the patient has to connect to the bag and patient has to remove it. So that is why you call it chronic ambulatory peritoneal dialysis. Now this is where you can do it with a machine. So this is called automated peritoneal dialysis. So here the patient goes to sleep in the night. Before he goes to sleep, he connects that tube in the tummy to this machine. And the machine will automatically do peritoneal. It will pump fluid in, take fluid out, and this will keep happening overnight while the patient is sleeping, and the patient won't even feel anything. In the morning when the patient wakes up, peritoneal dialysis has happened. He has had the dialysis for the day, and he can just disconnect himself from the machine and go and do his usual work during the daytime. So that is how a automated peritoneal dialysis works. And this is the machine that you do automated peritoneal dialysis. So the machine automatically works once it connects to the peritoneal, the catheter in the patient. So that is about peritoneal dialysis. Anything you want to ask about peritoneal dialysis?
Excuse me, sir.
Yeah.
So sometimes peritoneal dialysis is being done in patients with like leptospirosis and things like that. No?
Yeah.
It's acute kidney injury.
Yes.
So is there a difference between these two methods?
No, it's almost the same. Only thing, acute dialysis is only for a few days until the kidney function recovers, and you can remove the catheter after that. In Sri Lanka, we don't use the same catheters that we use for CAPD for acute dialysis because of cost issues. In Sri Lanka, we use the straight catheter that you have seen in patients with leptospirosis and all, which is much cheaper, and you keep it only for 2 or 3 days. And the prescription, that is the number of cycles we do peritoneal dialysis and the amount of fluid that we put into the abdomen and things like that, that is a bit different with acute PD compared to this. So there are a few differences in the prescription of peritoneal dialysis, but the modality, the technique, the principle is the same. Anything else? Okay, right. So the next part is, so which modality out of this is the best modality to use for patients? Now, there is nothing called best because both are equivalent in its own right. However, there are factors that will influence us to decide whether a patient is going for hemodialysis or whether a patient is going for peritoneal dialysis. So, for example, contraindications. So, contraindications, if you take, for example, when you consider patients with peritoneal dialysis, if they have previous abdominal surgeries where there are a lot of abdominal adhesions, or if they have mechanical defects like hernia, absence, or if they don't have any assistance or nobody is there to help at home, if these patients are physically or mentally handicapped people, or if there's intra-abdominal sepsis, these are contraindications for CAPD for these patients. So if you have one of these things, most of these patients will not be considered for peritoneal dialysis, and we have no option but to go for hemodialysis. So for example, this is the patient with an abdominal intraperitoneal adhesion following a previous surgery, and you can imagine if you put in a catheter into this, it's going to get strangled in this, and the PD catheter is not going to work. Similarly, for hemodialysis, if you have heart failure, low blood pressure, and if the patient can't sit or lie down for 4 hours for a dialysis session because of severe back pains or joint pains, those sort of patients, we can't do hemodialysis. Those sort of patients will have to go on for peritoneal dialysis. So your contraindications are one factor that governs whether you go for hemodialysis or PD. Then, whatever you use, both these modalities have its own complications associated with that. So if you talk about PD, you can get infections like peritonitis. The PD solution that we are using has a lot of glucose in it. So if you are a diabetic, sometimes it can worsen your glycemic control. When you go on doing peritoneal dialysis for years and years, sometimes this peritoneal membrane will fibrose and sclerose. So it will fail. Sometimes you get a condition called sclerosing peritonitis. So these are complications that can happen with peritoneal dialysis. Similarly, with hemodialysis, because we are dealing directly with blood, you can have hypotension when the blood is, going out of the body, coming back in. If you are doing a dialysis with these Vascat's temporary access, you can have access-related infections. You use a lot of water in these patients for dialysis, so sometimes these water contaminations that can cause problems. And there is a condition called disequilibrium syndrome, where initially when you start off dialysis, sometimes because of the electrolyte and osmotic changes, these patients can get fits and headaches. So these are some of the dialysis related complications. So that will also govern us to decide which sort of modalities to use. Then when talking about survival, more or less, so this graph is just showing survival on dialysis versus peritoneal dialysis. You can see that whether you use peritoneal dialysis or hemodialysis, your ultimate survival is more or less the same. So both modalities are equivalent when it comes to survival benefits. So nothing is better than the other one. It becomes a personal choice, and you need to look at the complications, contraindications to start them. Then the most important thing when it comes to renal replacement therapy is quality of life. Now, depending on the person, depending on the patient, they will have different requirements, because once you start renal replacement therapy, this is going to be a lifelong thing for them. So you need to always take their quality of life into account. For example, we'll talk about travel. If this is a person who's working and has to travel all around the country on a regular basis, for this sort of a patient, doing hemodialysis might not be the best option, because he can't be going into hospital every 1 or 2 or 3 days to dialyze, because he has to travel all around the country. For that sort of a patient, they might actually prefer something like peritoneal dialysis, because they can take the fluid in their vehicle, go to some place clean and do the peritoneal dialysis there. So that patient might decide to go for PD as opposed to hemodialysis. Then, for example, let's say physical functioning. If it's a patient who's finding it difficult to go into hospital, all of that, that sort of patient might want to stay at home and do something like peritoneal dialysis. So there will be different aspects to their lifestyle also, which will govern which dialysis modality they are going to use. So that's all I'm going to discuss about hemodialysis and peritoneal dialysis. The next mode of renal replacement therapy, and the best renal replacement therapy, is kidney transplantation. Kidney transplantation is superior to both hemodialysis and peritoneal dialysis. So most of these patients, always, whether they are on dialysis, peritoneal or hemo, we always encourage them to go for kidney transplantation. So we talk about two types of kidney transplantations: live donor kidney transplantation and deceased donor kidney transplantation. Live donor means you have a live person who's willing to donate a kidney for you, and that person can give a kidney. Deceased donor transplant is that when a person dies of, say, head injury or some other problem, that sort of person, if the patient and the family had initially said that they would want to donate their organs on their death, that sort of patients, we can take their kidneys for kidney transplantation, and that kidney can be going into a patient who requires transplantation. So those two types of transplantations, both are done very frequently in Sri Lanka, and that is available. You don't need to worry about this ABO and AB incompatible transplantation, so disregard that. But these are the two main things that you need to know. And in a transplantation, what happens? Now, you have your original kidneys. The new transplanted kidney is going to go into your iliac fossa. And there you can see the kidney, their renal vein will be connected to the internal or the external iliac vein. And the renal artery will be anastomosed into the external iliac artery in this patient. And the new ureter will go and get implanted into the bladder. So that is where the new kidney is going to get placed, and that is what the surgeons do during a kidney transplantation. And that is more than enough for you to know about kidney transplantation. You don't need to know more than that. Right. So that being said, the future is something like this. Nowadays, people are making artificial wearable kidneys, or small dialysis machines which are in a small belt, where you can wear wherever you go, so that on the go, on the move, you can get your dialysis without any problem, where you don't have to go into hospital to dialyze. This automatically happens. So this will slowly come into the markets, and this is something that's looked at very seriously all around the world with regards to continuous dialysis. However, this is going to be the next generation, the most eagerly awaited development in the transplantation circuits, where they are trying to regenerate kidneys. Now, most of the kidney parts have already been regenerated. They are still waiting to connect a few of the parts within the kidney into the new kidney. And if that happens, within the next decade or two, I think we'll be looking at regeneration of kidneys. That is, with your own tissue, you can generate a kidney for yourself and go for a transplantation with your own generated kidney. So that is the future that we are going to look at. Having said that, now we spoke about 3 modalities of renal replacement therapy. So are these replacement therapy options for everyone? So it's not for everyone. You can't go for all these modalities in all patients. Some of these patients, for different reasons, they will not go for any of this, and then they will go for conservative management or what we call non-dialytic therapies. Usually patients who are very weak and frail, if they have multiple comorbidities where they are not fit for any of these modalities, and in some instances there are patients who don't do well even if they go for dialysis. For example, right now I have a patient in the ward who's only 52 years of age and not doing very well on dialysis, and their quality of life has not improved on dialysis. And there are a lot of elderly people who would say, I have lived my life well, I don't want any of these dialysis major surgeries. When I have to die, I will die, and I'll just go with medications, and when the time comes, I will die. So, and then they will refuse any modality of renal replacement therapy. So for these sort of patients, these renal replacement therapy options are not the best. So for them, we go with medical management and conservative management. So thank you. I